Hi, I'm Dr. Thomas Polascik, and I will be speaking on the topic surveillance after image-targeted focal therapy. We'd like to discuss the definitions of success and failure, the role of PSA derivatives and other markers, the role of MRI in the post-focal setting, the role of biopsy, how to define residual disease, retreatment, and disease arising in the untreated zone. First, in regards to cancer control, not all patients are cured. This is not surprising. We can have failures with active surveillance. Unrecognized elements can progress. We can have failures with surgery where cancer has already escaped the gland. And then we have tumors that may be insensitive to treatment in radiation, chemo, or ablation. There are multiple terms to describe cancer control or the lack thereof. It's important to hold therapies to a similar standard. Post-RP, PSA should be undetectable. Radiation has consensus biochemical outcome definitions. Typically, they disqualify biopsy, especially early on. Many feel that ablation should mimic the definitions of radiotherapy, although there's no controlled studies attesting to this, but we do rely on MRI and biopsy information. So what markers do we have for post-ablation cancer control? First, we have our workhorse MP-MRI. We can do targeted biopsy of the ablation zone, and we have biochemical markers, specifically PSAD and potentially a PSA nadir. So what do we know about this topic? Well, 10 to 20% of clinically significant cancers are not identified by MRI. Therefore, if one argues that they're going to use MRI solely to judge outcomes, you will miss, by definition, a number of clinically significant cancers. Of course, on the other end of the spectrum, we can really do heavy saturation biopsies to find disease, but I think that defeats the purpose of a minimally invasive objective. Or we can wait for cancers to declare themselves, but then that's subject to lead time bias. Going back to hemiablation as the classic focal therapy model, you can see here that we have a treatment side and we have an active surveillance side. So many of us feel that we have to have an outcome that's based both on the surveyed side or the untreated plus the treated side. I would also mention that although this is the historic model, there are many papers still coming out reporting on hemiablation. And as previously discussed, this is a schematic of the different ways that we can perform focal. The benefit is that this is all customized. The disadvantage is that, as you can see from these pictures, you can have very minimal untreated parenchyma or quite a bit, and that can affect outcome measures, especially if you're using PSA. So back in 2015, I could convened a panel to discuss these items. It was multidisciplinary that involved pathology, urology, and radiology. As you can see, the people, committee members here, and they were representing 7 different countries. So let's start with biochemical measures. I think most people agree that PSA should be measured after focal therapy, but we've had several consensus that have addressed this so far. We do not have enough long-term data about the use of PSA in focal therapy. Many feel that it should be monitored nonetheless, collected for research purposes. It is a good marker, but it cannot alone define oncologic success. And unfortunately, we don't have any standardized definition of BCR, as does radiation oncology. Well, beyond PSA, there's derivatives and other molecular markers that we currently have and will be developed. What do we do with these? Again, currently very little evidence to incorporate these. But we do feel that it's important to collect these for research purposes. What is the role of MRI in the post-focal therapy setting? Well, fortunately, MRI is used for patient selection on the income intake side. It's used to guide treatment, and it's also used for surveillance. It can monitor both the treated and the untreated zones. We felt that there should be minimal standards for performance. We all felt that a 3T was probably the best if you have one available. If you have a lower power magnet, we felt that use of the endorectal coil would help boost the signal. When is the MRI performed? The committee and other consensus panels felt that we should probably wait at least 6 months. So most were split between 6 and 12 months after treatment, and then consider yearly thereafter. Now, to be fair, if one is doing focal brachytherapy, one should probably wait a little longer, perhaps a couple years, because the definitions of brachy failure differ, and typically they want to wait at least 18 months after treatment before making any kind of decisions. The optimal frequency of serial MRI is not known. It should be determined by patient factors and also resource availability. Of course, one can get an MRI if there's a triggering factor, and any positive MRI should lead to a targeted biopsy. As mentioned, focal therapy has two components, an active treatment side and an active surveillance side. For the active surveillance component, one would follow PSAs and periodic rebiopsy. For the focal therapy treated side, again, PSAs, MRI, and then a control biopsy. Now, we don't have any level 1 data, so we have to turn towards consensus panels to derive what we feel is best practice. There's been 4 that have discussed the role of biopsy after focal therapy. Pretty much these say the same thing. The latest group was the Polascik group this past year. Most consensus believe on targeted and systematic biopsy, anywhere from 6 to 12 months post-treatment. And the triggers are, rising PSA or based on MRI findings. Any new MRI lesion that's suspicious should also be biopsied. This is the latest paper on the topic. It was published in the Platinum Journal. Amir Labashi is the first author, looking at focal therapy follow-up. And as you can see here from table 3, PSA is followed fairly commonly like any other whole gland treatment. First one at 3 months and then every 6 months thereafter until stability. Imaging, we felt that perhaps the first one at 6 months, maybe 12 months, and then every year or so. It depends on resources and institutional policies. We kind of left that a little more vague. Biopsies, we felt that systematic should be done in the same setting as MRI guided. Once at either 6 to 12 months was reasonable. If the systematic biopsy were negative, then you'd follow your institutional active surveillance protocol or base it on triggering factors or clinical suspicion. If the biopsy, MRI-guided biopsy were negative, again, you would base it on your active surveillance protocol. And then in terms of functional outcomes, we felt it was important to follow these a little bit earlier. One wants to start assessing outcomes at 3 months, and usually these stabilize early on. So usually within a year, men are back to their baseline. Focal therapy failure, there's different types. Ablation failure, there's tumors left in the ablation zone. We call that residual disease. It does require histological confirmation. It can be monitored using MRI if needed. Targeting failure, somehow the energy is not correctly applied to the tumor spatially. One needs to have a margin, as discussed, perhaps a centimeter. And selection failure is basically someone who shouldn't have had focal therapy. Perhaps they recurred very early on. Definitions of success in the treated zone. You have immediate technical success if the case went well. If you have small volume 6 or very small volume 3+4, it's probably reasonable to follow. A failure is any kind of high volume 3+4 or greater. In the untreated zone, you can monitor low risk disease just like you do with active surveillance. But if you detect clinically significant cancer, one should consider further treatment. And I would argue to consider focal as a first step. Disease arising in the untreated zone should be handled in the same manner as de novo prostate cancer. If you can ablate it, that'd be great. You can keep the patient in the active surveillance pool, but with more extensive disease, one should consider traditional whole gland therapy. With persistent disease, there's no guidelines defined for the management of recurrent or persistent disease. It should be determined by patient functional status, histologic, radiologic, and clinical information. The definition of residual disease, what to treat and what not. Again, low volume 6, you can follow, use with caution, 3+4, and anything greater, high volume 3+4 greater requires retreatment. Definition of focal therapy failure, conversion to whole gland therapy based on a medical indication, clearly progression to metastasis or initiation of systemic treatment. Repeat focal should always be considered. It's being evaluated at this point. If you have failure in the treatment zone, it may be due to a number of factors, problems with disease localization, targeting, delivering the energy. The patient, however, should not be precluded from any standard practice prostate cancer treatment options. And if it's salvage focal, it's recommended when the reasons for the initial failure can be clearly identified and corrected. The retreatment, the role of repeat focal, this was addressed in a 2015 panel. We felt that if you have a retreatment rate of less than 20%, it's clinically acceptable, and retreatment rates of less than 10% with whole gland therapy is also clinically acceptable. What's the role of repeat focal therapy? There's little data at this point. The difficulty may depend on volume and location of the lesion, and you can switch to a different device if need be. So here's a paper from the HEAT registry that looks on second HIFU treatments. As you can see here, there's 821 with a first treatment, first focal, and then a 167 with a second focal, and they asked those patients how they were doing in terms of functional outcomes. There was a small mean increase in the IPSS score after a second HIFU, and a small mean decrease in the erectile function score after a second HIFU. As you can see here, with the second treatment, initially you get a bump, and then that settles back down. This is in regards to erectile dysfunction. The continence pad-free doesn't really change, and the leak-free rate is also very stable after a second HIFU. So a retreatment of focal may preserve urinary function. You have to consider if you're looking at in-field or out-of-field differences. The functional measures at 12 months, we want to use some questionnaires as discussed. Sexual function should be measured with IIEF-5, and determination of sexual activity is based on patient report. Continence is need to use pads or patient-reported leakage. Any deterioration of urinary function of IPSS greater than 5 points is considered significant. Again, functional measures, quality of life, there's no one that we felt was needed in terms of a validated questionnaire. You have some options. Complications are judged as in any other surgical complication. So in summary, you'll know functional outcomes by a year or so. Oncological outcomes, you'll know by 6 to 12 months. Maybe consider a final post-ablation biopsy at 5 years. PSAD should be used going forward, and perhaps consider a 5-year whole gland biopsy for active surveillance. Thank you for your attention.